ladies and gentlemen. My name is Nick Courtney. I'm a TVI at the Lighthouse International, and I've been asked to give you a presentation on optic nerve hypoplasia this afternoon. Optic nerve hypoplasia is a congenital condition, which means it's present from birth, in which the optic nerve is underdeveloped and small. The optic nerve is a collection of thousands of nerve fibers that transmit visual signals from the eye to the brain. The optic nerve develops during pregnancy, and optic nerve hypoplasia is a lack of these nerve fibers, not enough developed during pregnancy. Optic nerve hypoplasia is one of the most common visual impairments in children in America. Optic nerve hypoplasia can occur in one eye, called unilateral optic nerve hypoplasia, but it's more common in both eyes. It's not progressive and unfortunately cannot currently be cured. There's no known cause of optic nerve hypoplasia. It used to be thought that maternal diabetes, alcohol use during pregnancy, drug use during pregnancy, or having a baby when you were very young were factors, but these have been proven wrong. There's no one factor which causes this. It affects all socioeconomic groups and all races equally. Optic nerve hypoplasia may occur on its own, but it's usually found alongside neurological abnormalities. Children with optic nerve hypoplasia demonstrate a wide spectrum of visual functioning, ranging from very mild visual impairments to total blindness, known as no light perception. The effect on the visual field may range from a generalized loss of detailed vision, almost a blurring in the central and peripheral fields, to just a subtle peripheral field loss. A high percentage of children with optic nerve hypoplasia have nystagmus, which is involuntary movement of the eye. Nystagmus is associated mostly with bilateral optic nerve hypoplasia. As mentioned, it's a stable condition, does not deteriorate with time, and we have seen a mild improvement as kids grow older, as their brain learns to cope with the optic nerve hypoplasia and learns to interpret the signals going to the brain better. Along with this, mild light sensitivity, known as photophobia, may occur. Optic nerve hypoplasia is diagnosed by a direct examination of the eye by an ophthalmologist. The diagnosis is normally found when a small pale optic nerve is found. An MRI is used to check the diagnosis. It's difficult to predict the visual acuity of a sufferer just by looking at the optic nerve. That tends to be something that we find out later on. Optic nerve hypoplasia sufferers tend to present with other conditions as well. These include gross and fine motor skill deficiencies, deficiencies in cognition, speech and social interactions, and in some sufferers where a brain abnormality has been found, they may suffer from seizures. There's also issues with the pituitary gland found at the base of the brain. The pituitary gland is the body's master control gland, which makes and directs important hormones required for growth and development. Energy control, sexual development, bone development, they're all regulated by the pituitary gland, and if there's a severe issue with that, all these things can be affected. The visual behaviors and characteristics of a sufferer of optic nerve hypoplasia. The child's vision is characterized by a lack of detail, a depressed field, but this lack of detail isn't the same as taking off a pair of glasses. It's a constant blurriness and may not go away if you look from side to side. In certain cases, a specific field defect occurs, where children may not be aware of a person standing right next to them, or someone or something coming in from their peripheral vision. Children with optic nerve hypoplasia may be unable to locate and grasp objects because of a lack of depth perception. As mentioned, some children with optic nerve hypoplasia have mild photophobia. These children may squint, they may lower their head, avoid light, they may not want to play outside, they may turn away. All these things are a coping mechanism to deal with bright lights above or bright lights outside. When one eye is affected more than the other, an ophthalmologist may recommend patching the stronger eye, since amblyopia, known as lazy eye, can occur. Some feeding issues are also associated with optic nerve hypoplasia. These tend to be linked with the hormonal problems rather than the visual issues. A lack of interest in eating, diminished sense of smell and taste. They may wish to stick to one food rather than experiment with new and different foods. There may be excessive lip smacking, issues swallowing, again, all linked with the hormonal problems. There may also be behavior issues linked with children with optic nerve hypoplasia. These can be linked to the medical conditions that go along with it, the problems with social interaction. They can also be linked with the hormonal issues. They may have hypoglycemia, which is low blood sugar levels, which can make them irritable. It can also affect their attention span, make them inattentive. Children with associated central nervous system problems may be easily distracted, quickly frustrated, and act in a disorganized or impulsive manner. Teaching strategies. Each child diagnosed with optic nerve hypoplasia should receive medical monitoring and a comprehensive ongoing functional and educational assessment done by a TVI and a special education team. Teachers may need to increase the size, contrast and lighting of materials for a child who has nystagmus and bilateral severe vision loss because of greatly depressed fields. If the child seeing print blurry, increasing the font may help, changing the font may help, increasing the size may help. Lighting issues need to be taken into consideration. If there's photophobia, a child may not be able to concentrate in a room with bright light. When a specified field loss is identified, materials need to be presented within the child's visual field. The child should be encouraged to turn his head to look for people and objects outside his visual field. If a child has been diagnosed with unilateral optic nerve hypoplasia on his left side, that means his left side vision is going to be weaker, so objects should be presented on his right side. If he's sitting in class, he should be placed to the right of the teacher so that he can use his stronger vision to see. Turning their head constantly to compensate for a lack of peripheral vision is a strategy to help them so that things don't just appear out the side of their eyes. A child with optic nerve hypoplasia needs the opportunity to develop learned aspects of depth perception, fine and gross motor skills. You can do this by giving them as many different opportunities to explore puzzles and games. There also may be a lack of incidental learning, which is the things other children will learn just from watching the world around them. Things like toilet training is something that a child may pick up just from watching peers and adults use the bathroom as they grow up. A child with a vision issue may need to be taught how to do these things because it's not something they pick up incidentally just from watching. Nesting and stacking toys, container play, ball tossing, pouring activities, practice with stairs, slides, play that other kids may see and experience because they're comfortable in their environment and they've watched other children may also need to be taught to a child with optic nerve hypoplasia. Again, light sensitivity, the effects can be minimalized by adjusting light levels, wearing tinted lenses, and minimalizing glare on surfaces, visors, things like that. Whatever helps the child, whatever strategy you can develop with the child to minimize the issue. A child with optic nerve hypoplasia, as mentioned, often has other conditions that need to be considered when developing an individual education plan, an IEP. Again, there may be behaviour characteristics that need to be addressed, there may be cognitive issues, there may be social issues. All these things need to be included in the IEP and worked on by the team for the best interest of the kids. The child who's easily distracted or frustrated, disorganised or impulsive may be helped by predictable physical environments and dependable daily routines and limited distractions. A class with 30 kids, a lot of noise, a lot of activity may not be the best place for a child like this. They need some order, they need to know what's coming and how their day is going to play out. It helps them plan their day mentally and offers them a way to make strategies to cope with their day as they go through it. Slowing the pace of activities and providing predictable transition routines may also help reduce resistant and irritable behaviour. If we know a child is having a problem with a transition, sometimes a countdown will help. In 5 minutes we'll leave the rec room, in 2 minutes we'll leave the rec room, in 1 minute we will leave the rec room. Gives them a chance to plan ahead, and it's not throwing a transition at them which may cause issues. Offering frequent snacks to a child diagnosed with hypoglycemia will help control blood sugar issues. When a child does have feeding problems, the parents and the educational team need to agree on recommended strategies to create positive feeding experiences. Feeding and social interaction are things that may require a lot of effort because, again, the kids aren't learning this through watching their peers, which would be something a sighted peer may do. They may learn how to feed themselves by watching an adult scoop. That may not happen in a child with optic nerve hypoplasia. They may need assistance, hand over hand, verbal prompting, descriptions of how to do this. When a child has no functional vision, no light perception, or no light perception, an approach that utilises all senses and all different methods of learning is needed. And for many kids with optic nerve hypoplasia, an evaluation by an O&M instructor, that's orientation and mobility, is essential for meeting the child's needs. Due to a loss of detailed vision and field loss, there may be issues with transitions moving from place to place. They may be fearful, they may be concerned, they may not understand where they're going and how to mentally plan through their movements. Thank you very much.